And so with that, I'd like to kick off our first session. And I'm very excited to introduce our first two speakers, Dr. Vinnie Liu and Dr. Patricia Ordonez. And we'll start with Vinnie. Vinnie's talk is titled "The Future of AI in Healthcare is Augmented, Not Artificial Intelligence." Dr. Vinnie Liu is an MD who's a research scientist at the Kaiser Permanente North California Division of Research. His work focuses on the intersection of sepsis, acute severe illness, informatics, and healthcare delivery with the goal of building towards a learning hospital system. In addition to his research role at KP, he's an intensivist of critical care at Kaiser Permanente Medical Center in Santa Clara, California, a clinical assistant professor of medicine affiliated at Stanford University, and regional director of hospital advanced analytics at Kaiser Permanente North California. Thank you, Vinnie, and please take it away.
Thank you to the conference organizers for inviting me to join this exciting panel at the Machine Learning for Healthcare annual conference. The title I've given this talk reflects the reality that we face in applying AI and machine learning to everyday healthcare. So it's from this very frontline perspective that I speak today as a leader who oversees the development, instantiation, deployment, and evaluation of predictive models and computational tools in a health system caring for 4.5 million members. From this perspective, the key point I'd like to make is that to successfully deploy this incredible technology that undergirds AI and ML in healthcare, we need to reframe AI as augmented rather than artificial intelligence. Augmented intelligence places patients, clinicians, and communities, the people, rather than the algorithms, at its center. To some, this statement might feel provocative, while to others, it's simply a no-brainer, which I think reflects the value of this conference, to bring together researchers and practitioners from a diversity of scientific disciplines and perspectives to improve healthcare together. The talk will include three parts: a historical perspective, a modern day example, and then finally, how this comes together in our experience at Kaiser Permanente today. I feel extraordinarily honored to call my KP my home today because the underpinnings of ML, AI, and computing in healthcare are really in our system's blood. This obituary from the New York Times recounts the illustrious career of Dr. Maury Collin, who many of you may know as one of the earliest pioneers in the field of medical informatics. He happened to also be the founding director of the KP Division of Research, where I conduct my work today, and made the use of databases and computing systems a central part of routine healthcare delivery. But KP's history with AI and ML goes even further back. Dr. Sidney Garfield was the first physician of KP, and more than 50 years ago, he already identified the critical role that computing would have in managing patients and improving healthcare outcomes and value. In 1970, in Scientific American, he identified the need for algorithms that would reliably distinguish the sick from the well. In his recounting in the 1900s, healthcare was pretty simple here on the left. The only patients to receive care were very sick patients who might be admitted to the hospital, but with few diagnostic or treatment options. By the 1930s, we had an increasing diversity of clinician roles, diagnostic modalities, and care venues, which meant that both patients who were very sick or those who he called the early sick could be cared for. And by 1970, the complexity of the healthcare enterprise had increased considerably, which meant that triaging the worried well, the early sick, and the sick became increasingly important. Without any type of computing algorithms, he foretold a future for the healthcare enterprise that summarizes where we are today. Patients with poor outcomes because they were not appropriately identified and risk stratified earlier in their disease, allowing for interventions that were effective. A healthcare system of immense cost, but of low overall value, in which families increasingly face medical bankruptcy, and a system in which patients and clinicians feel lost in an increasingly Byzantine structure that seems to restrict the right care and access to care. Thus, his vision was a system in which all patients, the well, the worried well, the early sick, and the sick, were seamlessly directed to the various venues of care, like diagnostic testing and referrals, health counseling and education, chronic disease management and prevention, or hospitals and acute care at the appropriate time for their condition. At the center of this ecosystem would be computing systems that proactively separated the sick from the well, directed patients the highest value care for their disease process, and could facilitate ongoing learning and improvement. As we look around us in 2021 at all of where healthcare technology and AI and ML are being applied, we certainly see this vision echoed again and again in the types of systems that are being built, described, and sold. His work describes a future which pairs together these modern disciplines, data science, and what some call delivery or implementation science. And in my role at KP, my goal is to ensure the success of this handoff between these disciplines, because this handshake will be essential for leveraging AI and ML effectively, efficiently, safely, and sustainably in healthcare into the future. What can we learn from other industries about this handoff? I might one day write a book called Everything I Know About AI Human Interaction I Learned by Nearly Dying in a Tesla. In December 2018, I found myself in Seattle preparing to make a solo drive from a Tesla dealership there back to my home in Silicon Valley. Now, I'm pretty accustomed to making long drives, so it didn't particularly worry me that Google said it would take 13 hours. I figured I could shave off some time by pushing the speed limit, and I figured it'd be a very enjoyable ride in this used Tesla that I had just purchased. Of course, what better way to enjoy that ride than by using autopilot? This AI system, which I'm sure all of you are familiar with, has successfully and safely driven billions of miles, and it would let me sit back and relax while it took the wheel and directed me home. Now, never mind that I had never driven a Tesla, much less used autopilot, right? I mean, I watched the 5-minute YouTube video on driving a Tesla. And as the Tesla employee handed me the key fob, he started walking away to move on to the next customer. I called him back. Hey, can you show me how to drive this car? So there's much about a Tesla that's similar to any other car. You have a steering wheel, you have a stalk that can engage, park, reverse, or drive. You have some fancy steering wheel mounted controls. The center console lacks any physical buttons or dials, but it's pretty straightforward and familiar as a touchscreen. So as he was finishing up, he said, pull this stalk back once to engage adaptive cruise control, pull it back twice to engage autopilot, and push it forward to disengage. Enjoy your new car. And with that, I started my trip. Now, the Tesla has amazing acceleration that makes any new driver giddy with excitement or even feel a little bit sick to their stomach. And its low center of gravity gives it great handling. Things are going so beautifully that after 15 minutes, Leaving Seattle on I-5, I decided to engage autopilot, pull this stalk back 2 times. And that was my first key learning. I need a lot more training and experience in using this system to make the handoff safe. Have you ever wondered why those tire marks seem to go off the highway and then into the median? Well, I can give you one example of how that might happen. Immediately after engaging autopilot, the car surged forward to meet the set speed, and coupled with that acceleration, the car took over steering completely. Now, that's never happened to me because I've always been in control of a wheel, but I'm racing down a busy I-5 in the middle of one of the largest cities in the country, in the lane closest to the median, without any seeming control of the car. And of course, as panic set in, I realized I don't know how to disengage the autopilot. So using former technology, I figured, why don't I just take back control of the wheel? So I gave it a gentle nudge to the right. That didn't do anything, and the autopilot continued on its course. Well, how about if I give it a more forceful nudge to the right and break it out of the system? Well, that was a bit of a mistake because as I pulled the wheel towards the right, the autopilot interpreted that as a course deviation and forcefully counter steered me to the left, driving me on a course towards the median. I pulled again towards the right. Now to get away from the median. Again, it steered me back towards the median. Back and forth, the autopilot and I struggled for control of the car, swerving again and again until I braked, coming to a full stop in the middle of a busy highway. Learning number 2, AI human handoffs are essential to get right. We need easy ways to disengage the AI tools when they're not working correctly to achieve our intended goal. I felt incredibly lucky 15 minutes after leaving the dealership to not have ended up like this poor soul. I collected myself and I continued the drive home. I called my wife and told her I almost died on the highway, but I'm going to get home safely. And now I had a healthy bit of respect for a system which takes complete control of a car, hurtling forward at 70 or 80 miles per hour, that really can't guess what the other cars are doing around me or what's happening in the road. 2 hours into my drive, I came upon learning number 3. See, what I had thought was going to be a 12 or 13-hour trip, I realized might now take an extra 4 to 5 hours. Why? Well, because recharging this older Tesla wasn't like taking 5 minutes to fill up a conventional car with gasoline. Actually, charging the battery to make it safely to the next charging station, here indicated by the red dots, would take at least 40 to 60 minutes. Now, since I'd never driven this car, I didn't want to be stuck in the middle of Oregon, Washington, or California with a dead battery because I misinterpreted the indicator. There's a reason why the supercharger stations are laid out so regularly on this map. So this wasn't an AI issue, but it demonstrated the ways in which our assumptions about using technology may not come to pass in the way we expect when we've used our traditional tools. And this produced learning number 4. The new tools and technologies, including AI, begin to push us to do things we wouldn't normally do under regular circumstances. I found myself saying, well, this trip is taking much longer than I expected, but I'm pretty sure I can still make it home safely. Now, after hour 12, after midnight, this fatigue certainly started setting in, and I began nodding off during the drive. Now, at that point, with a regular car, I would have been forced to stop and defer the rest of my trip to the next day. But it turns out that on an open highway in the middle of the night, on an unbroken stretch, autopilot does amazingly well at keeping you centered in your lane and keeping a steady speed. So at this point, autopilot actually pushed me to undertake a dangerous path to getting home, putting my life at risk again. But I like to say it was at this point that autopilot also saved me, because without it, I would have certainly been in an accident. We can see that the use of AI opened up new choices, which I may not have intended or expected using older technology. Now, I think you certainly can begin to see how incredible this AI technology can be, but also as it is can be life threatening and life saving once this technology is applied to a real world setting. The autopilot feature continues to be updated by Tesla, at least in my experience over time, and many things have improved. For example, the steering nudge needed to overcome self-driving has actually become much easier, making this handoff and transition a lot more safe. I've also gained lots of experience in using the tool so that I engage it in the right situation, largely open highway, good lighting, clear lane markings, and then learn when I disengage it, particularly when there's lots of cars and trucks around me and they're moving in a lot of different uncertain directions, when there's certain poor lighting from the sun, or there's uncertainty in road conditions. It's an incredible technology and it augments my driving under the right condition. Of course, driving other cars like our Subaru Outback that has similar technology to the Tesla has produced other learnings. While this technology may have similar features, the augmented aspect of their eyesight product are actually quite poor. It alerts too frequently. It provides minimal and uncertain assist and benefit, thus making it hard to tell when it will engage and when it won't. So poor AI implementation and handoff is also incredibly frustrating and leads to me barely using it, even though the technology is actually quite strong. For those of you engaged in the deployment of AI and ML in your healthcare setting today, I hope this story feels extremely familiar. And we can see how this entire set of driving experiences is an object lesson for the types of struggles we already face and those which we will increasingly encounter as our tools are deployed at scale. Of course, using aviation, this type of experience occurs in other industries. For example, as described in The Verge, the poor handoff, the lack of training, and the uncertainty about how to disengage technology are cited as key reasons for the struggles the pilots of the Lion Air Boeing 737 MAX had before their plane was unfortunately lost. I'm going to close by describing how these object lessons have informed our approach to ensuring that AI is augmented intelligence in healthcare, mostly by working to engage both the data and delivery sciences. This is a list of some examples of predictive models which are currently running or under development in our health system. Our work on the first row on an early warning system for inpatients called Advanced Alert Monitor, AAM, was deployed, and we were very excited to see the results published recently in the New England Journal. The outcomes following implementation of our readmission risk score, the second row, will be forthcoming in a high-profile general medical journal within the next few months. And you can see here with selected examples, we're working on models in labor and delivery, HIV, surgical scheduling, mental health, emergency care, and population management. As we experience in our AAM model, the inpatient early warning score, there was a fair bit of work in developing the algorithm, particularly because the initial development done by Gabriel Escobar happened well before EHR and real-time platforms for predictive models were routinely available. A lot more time was actually spent in pairing the tools with workflows, as shown below, whether that included the user interface, the specific workflows and timelines, the communications around the score and its impact on care, marketing to ensure end user awareness, engagement, and sustainability, or the spread plan for evaluation and dissemination across our facilities and now across many of our regions. Being prepared to address these types of challenges right from the outset and gain endorsements from our clinicians and our stakeholders actually has a significant impact in the future on the type of AI and ML tool that we would choose to develop. For example, if we think of the specific intervention targets that might be available to us today, many of us aspire to have predictive models that are designed to inform a specific clinical decision at a specific point in the trajectory of a disease in a specific patient. However, by and large, I think we all know that our models, our performance, do not yet have this level of precision in them today. Instead, by stepping back and understanding the needs for these tools across a health system, we can define other potent targets, including those in resource utilization or in workflows that are ripe for vast improvement, even with models that have moderate or potentially poor performance. So, what does that mean? We have 1,000 patients that need this service. We only have resources to serve 200 of them. Let's queue them up. Alternatively, we're providing this service to 1,000 patients, but for 200 of them, they are very unlikely to progress, and we can potentially pull back. Or our workflow for this intervention is highly variable today. Let's use a predictive model, a quantitative value as a smarter starter gun to get our workflow standardized. Here's an example in sepsis, an area where we've seen a huge amount of attention placed on model development, validation, and deployment. Here on the x-axis, we start from the time point of sepsis hospitalization and the days that follow. And here on the y-axis is a, theoretical infection severity with over time could increase, leading to patients ending up in the ICU, here in the pink box, with septic shock. Now, I think many of you know that time delays in sepsis care result in worsened outcomes. And so a lot of attention is focused on the very earliest segments of care occurring right after hospitalization, as indicated by this orange stripe. And yet, when we begin to step back and look at a health system Pareto plot in terms of what actions will drive outcome benefits, the actions being the kind of the level of effort on the x-axis and the outcomes benefit on the y-axis, where many workflows are already in place for the early recognition of sepsis patients, through standardization, through other sticks and carrots. The remaining incremental benefit, even for high performing AI models, may be relatively small. And maybe some of you have experienced it, that the alert downsides outweigh any of the alert upsides in some cases. Now, of course, as described in the Tesla example, if we're able to level up with a tremendously high performing model, it can actually be embedded earlier in this process, integrated in a phase of the workflow that yields even greater benefit. But it is also true that a relatively modest or even poor performing model integrated early on could have a tremendous impact on outcomes simply by ensuring that the subsequent processes are well aligned and practiced in an effective and sustainable manner. And this gets again to the overall point of this talk, is that when we focus on the people, the patients, and the clinicians, and the communities, we begin to understand at which points we can enter in, use these tools effectively, rather than having the algorithms drive, because where they are inserted often is not relevant to the rest of the care. Now, as we've stepped back, we've seen the incremental benefit of earlier treatment in the hospitalization as quite a difficult target, and even that we cannot drive. There's a challenge of driving antibiotics even earlier when your median time to antibiotics is between 2 and 3 hours. And so we've stepped back, and more and more of our attention has focused on pre-sepsis aspects of care. So now we're looking as far back as 1 week from sepsis hospitalization. How can we get ahead of the hospitalization itself and use AI and ML tools in concert with other types of diagnostics and screening tools and standardized workflows to attenuate or even prevent sepsis hospitalization itself? COVID-19 has taught us that with the right compelling data and objective, we can rapidly stand up large-scale infection home monitoring programs that combine clinical data with instruments to screen patients for worsening trajectories that may or may not have an effective AI or ML component to them. However, these we've also seen require a careful pairing and handoff and handshake between the data and delivery sciences. I'm going to end the talk by making a plug for our fellowship at KP Division of Research, in which we focus on informatics and data science within a larger delivery science fellowship. Here, we train future researchers and healthcare leaders to understand how to bring these two disciplines together, to pair the optimal AI and ML tools with high impact problems across a large and challenging health system. If you are a trainee or you have trainees interested in this type of work, please have them take a look at our online materials, and we'd love to chat with them. I hope I've made this statement a no-brainer for you. AI and ML are extraordinarily powerful tools in our armamentarium, but focusing on successful health system prioritization, workflow integration, handoffs, training, disengagement, and then preventing unintended consequences will ensure that all of our collaborative work is effective, efficient, safe, and sustainable for the future of healthcare. The work I've described truly takes a village, and in particular, many of my colleagues, and I'll particularly note Gabriel Escobar and Patricia Kipnis, as well as many clinicians and stakeholders across a diversity of fields to achieve the goals and the programs that I've described. Thank you very much.